Bismillah ar-Rahman ar-Rahim. Some points in palliative care in a case of dyspnea in lung cancer. When we doing when we do palliative care for dyspnea in a patient with lung cancer, we should consider possible causes, which are pneumonia and COPD, pulmonary fibrosis, global collapse, pleural effusion, pneumothorax, periovena cave obstruction, and respiratory muscle weakness due to cachexia and paraneoplastic syndrome. And dyspnea may be due to underlying disease or due to additional pathology. Lung cancer and pulmonary metastasis are associated with sensation of shortness of breath, often due to stimulation of receptors by malignant infiltration or lymphangitis carcinomatosis. Dyspnea is a frightening and made worse by anxiety and panic. We should explain to the patient that alleviation of dyspnea is possible for most patients with appropriate treatment. We should optimize treatment of any underlying lung disease with bronchodilators and steroids if appropriate, and we should treat concurrent chest infection if present. We should give advice on planning and adapting daily activities to conserve energy and consider modifications to home environment, and we should teach breathing techniques such as diaphragmatic breathing and pursed lip breathing, and should consider exercise training. We can consider fan blowing cool air onto the face and consider opening the window, and should consider also patient positioning when in bed. Upright position assists diaphragmatic excursion, and lying tilted may help with copious secretions. We should treat anxiety and we should treat depression. We should consider use of opioids in a dose of 2.5 to 5 mg morphine, as for example, solution 4 hourly to relieve sensation of dyspnea without affecting respiratory function. And we should consider preemptive use for known triggers of breathlessness. Oxygen cylinders or concentrators for intermittent palliative use may help in removal of symptom of dyspnea and but may be associated with psychological dependence, and it may restrict daily activities and may dry the upper airways. So we should use it carefully. In a case of lung cancer, we should consider the need for external beam radiotherapy and endobronchial tumor debulking or airway stenting in those patients that experience dyspnea due to bronchial obstruction or compression due to the tumor. If pulmonary embolism diagnosed, consider treatment with low molecular weight heparin instead of warfarin. Subcutaneous opioid infusion may relieve symptoms as this approach, and it's used with haloperidol, midazolam, or levomipramazine may be considered.